Treating Inflammation in Dry Eyes by Professor Ashok Sharma. So, my teacher at PGI and now leading cornea specialist of the area. And I think he is having only dedicated cornea services in the area. So it's purely cornea services, including eye banking and keratoplasty. So I welcome sir and request him to please start his talk, treating inflammation in dry eyes.
Good afternoon, everybody. At the outset, I would like to thank Professor Suresh Gupta, Head Department of Ophthalmology, Government Medical College, to give me an opportunity to interact with you people. My topic is treating inflammation in dry eye. But before we go on to this topic, let me tell you that dry eye is a common problem, and that is the reason we are going to discuss it. And in some of the prevalence studies, the incidence is as high as 40%. That means that if you are dealing with cornea, every other patient may be having a dry eye. Yesterday only we had a patient who is well-known industrialist in Ludhiana. His complaint is just glare when he is walking outside in the sun. And he is diabetic also. All OCTs, everything has been done to him. But the reason for that glare or that photophobia was severe dry eye. And when we investigated him, he has some collagen vascular disorder also. So we should remember that. And all of us are doing cataract surgeries, and you will be surprised to know that the incidence of dry eye is much higher in patients who undergo cataract surgery. And up to 35% of the patients may not be satisfied with the outcome of the cataract surgery, not because of other complications of cataract surgery, but just because they had dry eye and they were not counseled and their symptoms have worsened, because the dry eye is known to worsen after cataract surgery. And we all know that if we have a very severe dry eye, then we don't use multifocal IOLs. I will not go into the details of the diagnosis of the dry eye, because today I am dealing with the inflammation only. But still I would like to comment that these are some of the common tests we perform. But if you look at the reliability, probably the tear film breakup time is more reliable than any other test like Sharma test or even ocular surface staining. Questionnaires, they are important because then you get the idea of the patient's symptoms. We all are aware that dry eye is a multifactorial disease, and there are different pathomechanisms in dry eye, tear film instability, hyperosmolarity, and then we have even MGD associated with dry eye, and hyperosmolarity leads to the cell damage and then to the neural inflammation, and again this becomes basically a vicious cycle. But of all these pathogenesis, inflammation is the most important component. If you look at the literature, in the recent years there has been a lot of interest generated in this area. My submission to you is that don't look dry eye just as a single entity. Look it as a multifactorial disease, look it as a syndrome, and then try to find out the etiology for it. And then you will be surprised to know sometimes the patient may be having rheumatoid arthritis, something else. And whatever is the cause for the dry eye, it's the worsening of the dry eye usually occurs because of the underlying inflammation. And this inflammation is not clinically visible. That is the reason it is also known as the white inflammation. There is ample evidence in the literature, both in the experimental models and also clinically, that this inflammation occurs in dry eye. Now, one example is that if you have a dry eye model created in the mouse, now if you transfer the CD4 T cells from these mice to the patient, to the mice who have T cell deficient, deficiency, these mice, they develop the dry eye. So this has a role. And then clinically also the immune cells, they have been demonstrated in the various sites of ocular surface on various investigations. So inflammatory cells are found in the ocular surface. Now this begins as T cell activation. I will not go into the details of these, but it's the calcineurin nephid signaling pathway which is important, which plays an important role. And both cyclosporin and FK506, which is we use as tacrolimus ointment, they inhibit this activity. Cytokine activation is another. Again, I am going to miss some of these details, but again, MMP9 is important marker. This is important because this indicates the status of the stressed ocular surface, and also it signifies that cell damage is occurring. And we can measure it. I will go come in to the MMP9 again later. And this MMP9 can be measured basically, and to categorize the patients. This inflammatory mechanisms, they change the components of the tear film, and inflammatory markers, they appear in the tear film, causing the inflammation or aggravating the inflammation further. So various these proteases and all these, they are activated, causing this. Another inflammation, another area which is important is nerve dysfunction, and if nerve this is also known as neurogenic inflammation. So this is important, and clinically when we do cataract surgery or when we do like LASIK surgery, we are cutting the nerves, and then this neural inflammation, that plays an important role. And you will be surprised to know that the dry eye associated inflammation changes the corneal microenvironment, and that change in the microenvironment can cause the loss of goblet cells, loss of limbal stem cells, the aqueous tear deficiency, immune cell infiltration into the corneal stroma. Even cataract has been reported, and decreased corneal endothelial cell density because of these inflammatory markers. And again, corneal nerve loss can occur because of these inflammatory cells. So this, if we translate all this information to clinically, we have worsening of the dry eye because of inflammation. You can see we start with the simple dry eye, then we can have all these evidences. And this is one of the reasons, this underlying inflammation is one of the reasons that the patient's symptoms and the signs, they do not correlate. Sometimes you have a lot of symptoms and the patient signs are not there, and that's the reason the your questionnaires are important. Now this is one example where patient had very severe inflammation. He was having dry eye to the extent that no anti-inflammatory drug was helping him. He himself was optometrist, and he used a topical anesthetic agent like Paracan of his own, because he was knowing that this is going to relieve his symptoms. So you can see what happened to a dry eye patient once he uses that, and the inflammation can be so severe that it can be symptomatic. MMP9 is important. We can test it just like any other test being done. We have kits available, and if the levels are more than 40 nanogram, then that is the indication that you can use surface anti-inflammatory agents like cyclosporin or tacrolimus or any other. I will not go into the details of all these treatments, but most of the agents, they can control inflammation, and one of the most potent is steroids. But we all know that the steroids we cannot use for prolonged because of its complications. So we have to rely on some of the other agents which are available to us. Just to name few, trehalose is one which is known to have like anti-inflammatory action, and it has even antiviral also. That was the reason in the COVID pandemic it became very popular. Another molecule which is not available but is again has almost similar action to cyclosporin. Cyclosporin is available to us, and this is a important molecule which can be used in dry eye. We have to be patient when we use cyclosporine because its effect takes a longer time. It's not that like steroid that we start it and we get anti-inflammatory effect immediately. And there are like patients where it may not work very severe dry eye, patients having keratinization or patient having neurotrophic keratitis. So these are the areas where this drug may not work at all. And there are problems with this drug that you need a oil-based formulation for this drug, and that the reason for that is that you need a high partition coefficient. You need higher concentration of this drug in oil base, and this is ideally to be prepared as topical as oil in water emulsion. I will not go into the details of this, but one formulation, Restasis has a formulation in such a way that the cyclosporine is dissolved in castor oil and oil phase is then emulsified with the help of the polysorbate 80 carbomer. And this is a stable emulsion, and one drop of Restasis releases 75 million small droplets. So that is the reason it's effective for ocular surface inflammation at a very low concentration. But again, all the other preparations available to us may not be prepared with the same method. They may be just the aqueous preparations which do work, but again the efficacy is much more if we use the proper emulsion. I will now come to some of the clinical cases where we have used it. In Sjogren's syndrome, it again along with that, it's not that you put cyclosporine only and you are going to get benefit, but along with other medications you need to control the inflammation. Now what happens is that if the Stevens-Johnson syndrome patients, we are not controlling the surface inflammation, the surface epithelial cells from the lid margin, they grow onto the conjunctiva, causing the lid margin keratinization. And then these patients, they will need procedures like lid margin mucous membrane grafting from the oral mucosa to make them asymptomatic and to prevent the further degradation of the ocular surface. So it's important that if we control the inflammation, we may delay these surgical procedures. In Murren's ulcers, again, along with the topical steroids, we can decrease the frequency of the topical steroids. These are some of the patients where we have used, like VKC patients. In adenoviral keratitis patients, it can be used as a steroid sparing agent, because if we use steroids for a longer time, we are going to get complications of this. This is another patient who had rheumatoid arthritis along with he had corneal problems. We have to do penetrating keratoplasty for him. So these are the patients where, in addition to the topical steroids, we give sometimes topical cyclosporine also. As I discussed earlier, it's very important to treat the dry eye before we take patient for surgery, especially for cataract surgery. Now this patient came to us at a stage when she has developed infection, corneal infection along with endophthalmitis in right eye. And because of the infection we treated for the ulcer, we were not able to give her vision in this eye. But when we were, she had severe dry eye in the other eye also. So we treated dry eye in the other eye for at least 6 months using all autologous serum drops, cyclosporine drops. Then we performed the cataract surgery with better outcomes. So it's important to control the dry eye, find out what is the cause of the dry eye, because if autoimmune disorders are underlying mechanisms, then you may be prepared to deal these patients with aggressive treatment, and pre-op even immunosuppression may be given to these patients. Now this is another patient who is known to me. He is basically one-eyed, and he was having severe dry eye. He had SPK also, so he was needing cataract surgery. He used to go everywhere. Everybody will say we will do tomorrow. But the key is that you treat these patients. If the patient is having SPK, at least give autologous serum or other drops, preservative-free drops to treat the dry eye, and then perform the surgery, and be prepared to be sure that the dry eye may worsen after cataract surgery and symptoms may increase. So that also we should know. In this patient, we have even applied the puncture plugs, and after treating the dry eye, we performed surgery with good outcome. So in the end, I would like to say that inflammation is one of the key mechanisms in the pathophysiology of dry eye. Irrespective of the etiology, chronic subclinical inflammation is crucial in dry eye patients. Long-term treatment of ocular surface inflammation is of paramount importance, and cyclosporine is one molecule which is effective in reducing the signs and symptoms of dry eye and with no adverse effects. But it takes time, and we sometimes when we have to use this drug in patients who have active disease or symptoms, we may use topical steroids also for a shorter duration so that patient can tolerate this drug. Thank you so much for patient hearing.